Hey everyone, this is Paul from Ortho EvalPal, and I'm here to just give you a little tidbit of information on how I utilize BFR in the clinic. I've been a physical therapist for 29 years, and I'll tell you a little bit of my story on how I got involved with blood flow restriction, and then we'll just kind of go from there, and I'll answer some of the common questions that I get from people when we do these courses. It was about 1.5 to 2 years ago. I had a patient who had an osteochondral lesion on the backside of her kneecap. They essentially took the fracture out. They put in a cadaver piece of cartilage in there, and then she was non-weight bearing for about 2 months, and then started to slowly try to progress back into some strengthening, some range of motion, and all of that stuff, all per protocol. But we hit the 4-month mark, and we're really not getting anywhere. Now, this was a very active, very good athlete, soccer player, basketball player, was very well known for her basketball skills, and she just could not continue doing what she was doing. She couldn't change direction, she couldn't jump, and it just got to a point where she had to have surgery. Well, as we are trying to rehab her, she is just hitting a plateau. She's having pain, swelling, weakness. We just can't get over the hump. So when I spoke to her doctor who did the transplant procedure, he asked me if I'd ever tried any blood flow restriction with the patient. And I said I'd heard about it, but I had never tried it before. So that's when he hooked me up with Susie, and Susie took me through it. We did some training, and then I started the patient up on it. Now, adding BFR was the only thing that I had done differently with this patient, and within about 1.5 to 2 weeks, she had seen a significant improvement in her strength, in her decreased swelling, in her motion, and even her ability to walk and function. Even started getting into like a jog and higher speed activities within about 1.5 to 2 weeks after we started it. And that was the only thing we had done different with the patient. So from that point forward, I was really excited about BFR, and I was really interested in how it worked a little bit more on a physiologic level. So that's when I took Susie's course, and from there we just started using it more, doing it more. And I thought what I would do is talk today a little bit about some of the diagnoses that I use it with, and I would also talk about some of the little tips that you learn once you've done it with some patients for a while. So first, let me just take questions, and I will take one from you in that corner. Yes, okay, so how soon after surgery can you see these people? And so what I've been doing is waiting for at least 2 weeks after surgery. They've gotten over the initial part of the recovery, which can be somewhat difficult if it's been a total knee and ACL reconstruction or biceps repair, or whatever it might be. I usually wait a couple of weeks. The incision's closed up and there's no drainage, no sign of infection. So I think that is a good time to get started with it. And I think if you look in more of the recent literature, you'll see that that is a common time frame to start blood flow restriction. Any other questions? Yes, you over there. So should the patient wear anything in specific, like when they come in? Okay, yes. So what happens is oftentimes when you're putting the band around the patient's thigh, it can get a little uncomfortable. And so it can be uncomfortable in a couple different ways. It can be a little bit uncomfortable on the skin. So what I tell people to do is I have them put like sliding shorts on or compression shorts, and then I'll have them put their regular workout shorts over that. Women will like to wear like leggings, and that works really well. Okay, so you get rid of that physical discomfort by putting something on the skin before putting the band on, and that can help. I've put it right on my skin and I'm perfectly fine with it, but if some people have sensitive skin, then that can be helpful. The other thing is that if it's a male applying the BFR on a female or vice versa, and you're getting right close into the groin here, it just makes that a little more comfortable. And I explain to them ahead of time that we need to put this as high as we can, not on top of the belly of the muscle, but a little higher toward the groin. And there's an expectation that that's where it's going. Then It's a little more comfortable, especially if you have like leggings or if you have some sliding shorts or compression shorts on. Same thing with the arms. If people are a little uncomfortable in the skin here, then using a t-shirt and then putting it over the t-shirt, and that is perfectly fine. Now, any other questions? Yes, you over there. A little louder? Okay, yes. So, do you ever need to make adjustments to the bands when you are doing the treatment with the patient? And the answer to that is yes. So, typically you do 30 repetitions, take a 30-second rest, and do 30 repetitions and 30-second rest and 30 repetitions again. And then you take a 2-minute break between exercises. So, let's say you're doing straight leg raises and then you're waiting your 2 minutes before you go do calf raises. That's a good time to put the pump back on and check the pressure to make sure it is back to what your starting pressure was. Now, I typically go a little bit lighter with people when they first come in, only because I want them to become comfortable with it. Okay, and if they're comfortable the first day, then I might increase them a little bit because, again, ultimately we want them to be fatigued when they hit their 30 reps or fail around the 30 repetition mark. Now, some people have a, more muscle bulk on one side than the other, and they'll say, yeah, they're both at the same pressure, but one feels a lot like there's a lot more pressure in there, or it's a little more uncomfortable than the other side. I may adjust that. I may go a little bit less on the side that has a lot more bulk, and I may go a little bit more on the one that doesn't, just so that we get that same effect when we hit our 30 repetitions, that same type of fatigue. Okay, so I may adjust those by 25 millimeters of mercury. That's not uncommon. You'll see that in the video that I do with the young man who had the Achilles rupture. The other thing that's important is, when you check that, you check it every, between every set of exercises, because the bands will naturally lose a little bit of air just from being in a different position. I like to make sure that they're in a rested position. So back on a chair like this with the legs at 90-90. Or the arms are sitting like this. If they're holding their arm up like that, the muscles are contracting in the arm, and that can deceive you in regards to the amount of pressure that's in the band. So I like to just get them in a nice relaxed position. I'll snap them on, check them, make the adjustments, and then, they're still recovering in that 2-minute period, so that is perfectly fine. The other thing that I find that is very, very important for patients is that you talk to them about what they should expect when they're using BFR. Just like any other modality. Let's say you're using iontophoresis on a lateral epicondylitis. The sensation of direct current is a little bit sharper. It might be like a hot needling feeling. It might feel different than alternating current or pre-modulated current that you might have done with a patient that felt really comfortable and fuzzy and whatnot. So, talking about the expectation is important, okay? You're gonna tell them you're gonna feel this sense of pressure. You're going to fatigue faster. Your heart rate might start to race a little bit faster than what you would think because you're only using like 1/8 of the weight that you usually use. So you might start to breathe a little heavier. Your heart might race a little bit more. And Susie's going to talk about the physiologic reason why that happens. So if they know that ahead of time, they'll feel a little more comfortable with that. The other thing that they need to be careful with, and as we talk about safety here, let's say that you have somebody doing some leg presses on a machine and they have BFR on their legs. Their legs are going to be pretty fatigued when they get off that machine. They shouldn't just get up and stand on their legs because they may have a sense of wanting to give out. So like our gentleman that we had with the Achilles rupture, yes, he has a great opposite side to put weight on, but if that leg is fatigued out, he may give a little bit and tend to put weight on the affected leg. Take that into consideration. They need a little recovery. They need to kind of kick back, relax, get their feet under them, maybe just stand slowly and then kind of put some weight on. So little safety things like that you need to remember, okay? I'm trying to think. If you hit, let's say you're trying to get this 30-30-30 repetition process going, and maybe they get the first set of 30. They're doing straight leg raises with a 2-pound weight when they typically could do it with 10 pounds if they didn't have the BFR. And they get to their 30. And great. Now they do that round again and they're really fatiguing out at like 15, 16 and they feel like they can't continue. You can do one of two things. You can take a little bit of pressure out of the band and see if they can get closer to that 30. You can reduce the weight also. Okay, so sometimes I will just kind of drop the weight in half and see if they can continue on, or you can stop them there when they have failed. I like to get them closer to that 25 to 30 repetition failure point, so I might just drop the weight and have them continue so that they can get closer to that point. And so once you've played with that, you might find that, well, 3 pounds might be a little too much. Let's start with a pound next time and see if we can get all 3 sets of 30 or really close to that 30 to get to failure. Okay, so those are little tips that seem to work really well. I love the BFR because there are a lot of ranges we need to avoid, or there's a lot of weight we need to avoid. So some of the diagnoses that I've treated with this, where I've been able to treat earlier and activate those tissues with BFR that I couldn't with others, would be things like a distal biceps rupture. So I had a gentleman who obviously we couldn't start lifting heavy weights, so we put the BFR on. We did some wrist exercises, maybe some supination and pronation, very gently. Of course, with a biceps rupture, we want to be careful with supination. So instead of using a weight, we could just go with something that is really, really light and just go through the motion. And I kid you not, that arm will fatigue, but not put a lot of tension on that repair. And so I can even start with some light bicep curls, just lots of reps, but no weight. We've had patients come in. We had one come in with an olecranon fracture. He fractures the olecranon spreading pizza really, really fast and really repetitively, and it fractured off. And so when that was healed enough to start therapy, we actually were able to start him pretty quickly with BFR because we were doing no weight and then progressed to 1 pound weight, and even the light weight was really fatiguing him. And we developed a program that progressed faster than I had expected. We have also done ACL reconstructions. We do a lot of this rehab. We do a lot of it, within 2 weeks after surgery, so that we can just kind of prevent that atrophy from happening. Here's an example, like how many people, show of hands, how many people avoid open chain knee extension right after ACL reconstruction? Most everybody will avoid it. Why do we avoid it? You in the back? Yes, because you don't want to put an excessive amount of strain on that newly reconstructed ACL. Okay? And so what we know though is that it's more detrimental to the patient to have a sloppy, weak quad that is suppressed months down the road. So why not activate it early by putting blood flow restriction on the leg? You can even put it on the other side. You can do the arms also to get more release. But you put the blood flow restriction on and start with a pound at 2 weeks or 2 pounds. You're not going to put excessive strain on the ACL just going through the motion of extension, but you're definitely going to start firing up that quad. And so if you can prevent that atrophy and start to get it to activate earlier, you're going to have much better leg control. And I had a patient recently who had a meniscus repair and ACL repair. We started off really early on BFR. We actually did some prehab also. At 8 weeks, it looks like somebody who's at 4 months. I mean, nice, beautiful quad contraction, very minimal atrophy, walks like you wouldn't know that there's anything wrong. We've done them on ACL reconstructions. We've done them on patellofemoral dysfunction. These folks can't contract really hard. They can't do an open chain knee extension very well. Or if they can, it may be just in a very limited range. So why don't we kind of burn them out and activate them in that limited range? So we may just say, okay, instead of going from 90 to 0, we're going to go from 90 to 45. Throw the BFR on there and really get that quad burn, because with patellofemoral dysfunction, it's important that you get the quad to contract, right? We all know that the research has shown it doesn't really matter where you put your feet. If you externally rotate, internally rotate, jack the heels, whatever it might be, what you want to do is activate the quad without causing more patellofemoral pain. And this is a great way to do it, so you can get those reps without injuring the patient. That's just a few. I mean, we've done total knee replacements, and the very interesting thing too, people always ask about the concern of swelling. If there's swelling in the knee and you're putting a tourniquet type of device on the proximal thigh, how detrimental is that to that swelling that's in the knee? And to be totally honest with you, for those patients who've had knee surgery and gone through BFR, I've had 2 recently who had like this chronic swelling in the knee, and the day after we did BFR, there was like noticeable decrease in swelling. It was kind of incredible, and as I'm not the physiologist here, Susie is. She can probably answer why that happens in regards to the flushing process, but as far as clinically and with experience, I've seen that help to decrease swelling in the area, so it can be very beneficial for that. Now, any other questions? You over there. Yeah, okay, so can you use this with somebody who has back pain? Well, interestingly enough, I have had several patients who have had a history of fusion, and as you know, people who have had a fusion surgery, typically if they are smokers or if they are really deconditioned, surgeons may be a little more apprehensive about doing surgery on them because they really need that new bone growth. And a lot of these people are undergoing or utilizing bone growth stimulators to try to get that bone to kind of reabsorb and become harder sooner. And so what we've been doing is using BFR on the arms and legs, and we've done this with a couple of people who have had fusion surgeries and have done really, really well. The other scenario that this works really well with is the aging patient, aging athlete. Maybe it's somebody who really wants to be active, likes to exercise all the time. I've had 2 people around 65 to 70 years old who have been lifting heavy weights all their lives, but now their joints just are not tolerating military presses or maybe deadlifts or things like that. And so we've placed them on BFR with a lot less weight, getting the same response that we would if they were lifting really heavy weight, but we're just not beating up those joints, we're not overstressing those soft tissues. And so these people have really liked using BFR for that, just because when they're done, they feel like they've had a great workout, but they don't feel like they're spent. And they're not sore for days, so you can do BFR, several days in a row if you want. You don't need to take that big break in between because you're really not tearing up that tissue like you are when you're doing really heavy weight and low reps. So that's where I like BFR also. We've seen this kind of transition. Now, patients will oftentimes ask, once they've done some BFR, they really, really like it. They say, can I do this at home? Can I get a set for myself? And I'm apprehensive to let just anybody out there start with blood flow restriction. And I don't care really how safe the system is. I know that the ones that we use, the Be Strong system, is super safe. And so I'm more encouraged and inclined to let those people use that system. But I really make sure that they are comfortable using it in the clinic for several visits, okay? It might be 4, 5, 6, 7 visits. I make sure they understand. I have them apply the unit the second time they come in or the third time they come in. I walk them through it exactly where I want it to be, and I talk them through it and they apply it. Then on maybe the 3rd or 4th visit, I say, okay, now I want you to apply it to yourself on your own. And so I just watch what they do to make sure that they get it correct. Make sure that the valves are pointing inward. Make sure that they are in the right position. Make sure that they have the right pressure, that they're watching what's on the card. They know how to adjust themselves. They know how to make the adjustments between exercises. I also give them a handout of multiple upper extremity exercises or lower extremity exercises that are beneficial for those people when they are, if they just want a general exercise program. So I might help guide that program that they're going to do with the BFR. I try to make sure they don't work out much more than maybe 30 minutes with the BFR before releasing it for about 4 or 5 minutes and then kind of reinflating if they were going to go a little bit longer than that. But you can do this with just about anybody. They could go out for a walk. You can put it on the arms and legs. That's what my wife and I do. We bought a trainer's pack. It just works out that her thigh is a little bit bigger than mine. My arm is a little bit bigger than hers. So I use the reds and the blues. She uses the yellows and the greens. And we go out for a walk. And you don't need to be doing heavy exercise while you're using it to get the effect that you need, to get that systemic effect. So as you folks all know, I'm doing this in a very, very tiny room. You can hear the echo. So there isn't an audience out there asking all these questions. But I hope that I was able to maybe get ahead of you a little bit on some of these questions that you were thinking of, but if you have other clinical questions that you have for me, Susie has my information. It's in the packet. Feel free to email me, contact me, Instagram. I'm on Instagram. I also have a heavy YouTube channel with about 420, 430 videos on it about anything orthopedic. Some of it is blood flow restriction related, but so you can gather a lot of information from that. If you have questions, though, email me. And I would be more than happy to jump on a Zoom video conference with you if that's what you'd like, or I can even answer those questions through the email. The other thing that I can do is, like, let's say you have a question that is maybe a little more complex to answer. I may just throw up a video on YouTube for you and for the rest of the world to see, so that we can help answer that question. Be more than happy to do that. So folks, I hope you have a great rest of your day today. I hope that you enjoy the lab section of this. Make sure that if you have any questions, you ask Susie, so that when you get back to your clinic and you start utilizing this stuff, you're comfortable. But we are there for you if you have any questions whatsoever. And so I hope you enjoy the rest of today, and you're not too burnt out when you're all done. Again, thanks. I'm Paul, and if you have any questions, let me know. Take care.